previous module, we have already started with the nerve supply of the nose, where we have seen how the olfaction is mediated. We have seen how the sensory nerve supply of the nose is by the ophthalmic and by the maxillary. And we have seen the clinical significance of all that. Now, what is the third nerve supply of the nose? And if you have not seen that module, please see that module before you see this module. So yes, what is the third nerve supplying the nose? Yes, that is for the parasympathetic supply, that is for the nasal secretions. So that is the parasympathetic supply of the nose, and that is for nasal secretions. Nasal secretions. Why is this required? Nasal secretions. Why do we require that? Yes, and also parasympathetic and sympathetic, that is for vasodilatation, vasoconstriction. Why do we require that in the nose? Yes, did we see that the sensory supply, what does it do? It senses the temperature. It senses the irritants. Yes, it just senses. What does it do reflexly? Yes, it first senses that the temperature is not of body temperature. It is very hot, it is very cold. And then what does? It reflexly increases the secretions. For humidification, it reflexly causes vasodilatation. For temperature regulation to occur, when it senses the irritants, it causes increase in nasal secretions. Yes, that is for pushing out the irritants. So all this increase in nasal secretion, vasodilatation, that is occurring to the parasympathetic system, which means that the parasympathetic system works in conjugation with the sensory system most of the time. So whenever the sensory system senses that the air is not of body temperature, it stimulates the parasympathetic system, and then the parasympathetic system acts on the vessels for vasodilatation. It acts on the mucus glands for increased nasal secretions. So this acts on for the nasal secretions, for vasodilatation. So now this parasympathetic supply of the nose is by the Vedian nerve. It is by Vedian nerve. Vedian nerve. Now what is this Vedian nerve? The Vedian nerve is formed by two nerves. It is formed by the greater superficial petrosal nerve. Sounds very familiar, no? Greater petrosal. Very good. Branch of facial. Yes. Yes, branch of facial. And the second is deep petrosal. Deep petrosal. What is deep petrosal? So yes, greater petrosal is a branch of facial. That is what you told me. And what is deep petrosal? Deep petrosal is the sympathetic plexus around internal carotid artery. And what is the sympathetic plexus? This is the sympathetic plexus from the superior cervical ganglion. So greater superficial petrosal comes from where? Yes, from the facial, means it is coming from where? From the ear. So we know that this is the area of the ear. Yes, the petrous bone. Yes, very good. We have the petrous bone here. So from the first genu comes out the great superficial petrosal. So where does it go then? Yes, from the first genu, the moment the great superficial petrosal is given, it immediately enters the cranium. So we have somewhere here the opening for the great superficial petrosal. It enters the cranium. Why? Yes, to fuse here with the deep petrosal. So here we have the internal carotid also. We know that internal carotid has a petrous part, and then it comes out, it runs through the carotid canal and comes out here at the roof of the foramen lacerum. So here we have the sympathetic plexus around the internal carotid. They will fuse with, now let me just rub the internal carotid. So now the sympathetic plexus around the internal carotid, they will fuse with the greater superficial petrosal, and the fusion of these two is what is known as the Vedian nerve. So Vedian nerve is formed by the fusion of greater petrosal and deep petrosal. What greater petrosal is, we know that. What deep petrosal is, we know that also. Now it is in the brain, it has to come out. Where will it go out? Through the, yes, through the root of the sphenoid bone to the root of the pterygoid plates. There is a canal which is known as the pterygoid canal. Just notice here. Okay. So this here is the greater petrosal. This one is the greater petrosal. It has fused with the sympathetic plexus around the internal carotid, and the fusion, this here, this nerve is what is the, this is what is known as the Vedian nerve, and this is passing through a canal in the pterygoid plate. This is the pterygoid plate. Can you notice? This is the pterygoid plate. So at the root of the pterygoid plate, now I am rubbing this. Now you will be able to see this nerve, the yellow nerve that is going there. So this is the pterygoid canal. So since the Vedian nerve passes through the pterygoid canal, the Vedian nerve is also known as nerve of pterygoid canal. Nerve of pterygoid canal. Yes, and the pterygoid canal is also known as Vedian canal then. Okay, so here it passes through the pterygoid canal, and can you make out where it is coming directly? It is now directly coming into the sphenopalatine fossa. Yes, so till here, is that clear? Now let me first show you the Vedian canal. Yes, it is in the root of the pterygoid plate. So now here, when this picture was given to you this year, the choices, what was marked was this foramen, and was asked what this foramen is, and one of the choices was Vedian canal. So where's the Vedian canal? Yes, so this one at the root of the pterygoid, just at the root of the pterygoid. Can you make out this? At the root of the pterygoid, this is the Vedian canal, through which the Vedian nerve is coming directly into the sphenopalatine fossa. Is that very clear? So this here is the Vedian canal. This is the Vedian canal. And this is the foramen rotundum. Is that clear? So these are the two foramen that are present in the pterygoid root, and through the pterygoid root, the maxillary nerve and the Vedian nerve, they enter directly into the sphenopalatine fossa. So let me draw this for you first. So we have the skin of the cheek, we have the anterior wall of the maxillary antrum, the cavity and the posterior wall of the maxillary antrum. We have the orbit here. Yes, we have the base of skull going down slanting. Here we have the two pterygoid plates. Yes, and here we have the pterygoid canal, right? We have the pterygoid canal through which the Vedian nerve, which is the fusion of greater superficial petrosal plus deep petrosal. So the greater superficial petrosal is the parasympathetic, whereas the deep petrosal, which is the sympathetic plexus around the internal carotid, that is the sympathetic part of this Vedian nerve. So it has both parasympathetic and sympathetic part. So now it has come into the sphenopalatine fossa. Now in the fossa we have the ganglion, the sphenopalatine ganglion. The sphenopalatine ganglion is the largest parasympathetic ganglion. Largest parasympathetic ganglion. The greater superficial petrosal will relay in the ganglion. The deep petrosal will not relay. So both of them will go into the ganglion, and the greater superficial will relay into the ganglion, and the deep petrosal will pass through the ganglion without relaying. And now ultimately through the ganglion is passing some other nerve also, no? Yes, the ganglionic branches of the maxillary. So they will now be distributed through the maxillary nerve, to supply lacrimation, nasal secretion and palatine secretion. I told you that the sphenopalatine ganglion is the largest parasympathetic ganglion. Yes. Why is it the largest? Because it caters to the parasympathetic supply of almost whole of the face. The lacrimation, nasal secretion, palatine secretion. And when we did in the ear, the great superficial petrosal nerve, when we read in the facial nerve, did we read that? Yes. Did we do there that the great superficial petrosal is responsible for supplying lacrimation? Not only lacrimation, also nasal secretion, also palatine secretion. And if this nerve gets sectioned, there is dry eye. Did we do that? Yes. So from the ear, it does not directly come like this to supply the eye lacrimation. It from the ear, the greater petrosal goes intracranially, fuses with the deep petrosal to form the Vedian nerve, which passes through the pterygoid canal, to enter into the sphenopalatine fossa, and from here, this is how it supplies the lacrimation, the nasal secretion, and the palatine secretion. Is that very, very clear to you? So what we read is that the sphenopalatine ganglion has both parasympathetic and sympathetic part. The parasympathetic part is by the greater superficial petrosal. This will relay in the ganglion. Yes, and this will act either directly or through the sensory, when the sensory nerves will sense temperature which is not body temperature, a very dry air. So it will stimulate it, or irritant that it will stimulate it. And on the vessels, what does the parasympathetic cause? What does parasympathetic do? Vasodilatation or vasoconstriction? Vasodilatation. Vasodilatation. And on the mucosal glands, it acts to increase the secretions. Whereas the sympathetic is by the superior cervical ganglion, which do not relay in the ganglion. And on the vessels, what does it do? Yes, it does vasoconstriction. Vasoconstriction. And in the nose, this parasympathetic and sympathetic is controlled by the autonomic nervous system, where the control is such that both the nostrils do not function optimally at the same time. At all the time, both of them are not functioning equally. In one nostril, whenever there is vasodilatation, in the other nostril, there is vasoconstriction. This is what is known as nasal cycle. And this nasal cycle occurs at an interval of around 2.5, 2.5 to 4 hours. This is alternate congestion and decongestion because of the autonomic nervous control, and this occurs at 2.5 to 4 hours. So in one nostril there will be vasodilatation. After 2.5 hours to 4 hours, that differs in different individuals. It will change. In this nostril there will be vasoconstriction, the other will be vasodilatation. Again after 2 hours or 4 hours, again it will change to here vasodilatation, here vasoconstriction. That is what is known as nasal cycle. Oh, so quickly tell me now, parasympathetic supply of the nose is by? Yes, you will have to tell me. Yes, VDN nerve. VDN nerve is formed by greater petrosal and deep petrosal. Yes, greater petrosal is a branch of facial. Greater petrosal nerve, if it gets sectioned, it will lead to dry eye. Yes or no? Yes, it will also lead to dryness of nose. Yes or no? Yes, so it is responsible for lacrimation. Yes, for nasal secretion. Yes, for palatine secretion. The parasympathetic causes vasodilatation or constriction? Dilatation. Sympathetic causes vasoconstriction in the nose, and this is from where does it come? Yes, from the superior cervical ganglion, that is the sympathetic plexus around the internal carotid. So we just saw what the sensory as well as the parasympathetic supply of the nose is by, and let us see now how it is important to us in clinical scenarios. So now whenever there is any external irritant that enters our nose, what happens is that the sensory nerves sense the irritant and they reflexly stimulate the parasympathetic system, which causes the vasodilatation as well as it acts on the mucous glands to increase the nasal secretions. Now, what happens when this occurs? Whenever there is an irritant, in response to that, there is vasodilatation and increase in nasal secretions. So what happens because of that is that there is vasodilatation. The vasodilatation will lead to, yes, we know that in the nose, the blood supply is very immense. It is exuberant for temperature regulation, for humidification. So when all the vessels get dilated, what will happen? Yes, the nose will get obstructed. So this will lead to nasal obstruction. And increase in secretions, that will lead to increased nasal secretions. On the mucous glands, when it acts, it leads to increased nasal secretions. That will lead to postnasal secretions, that is known as postnasal drip. The secretions that will increase will not only come out from anteriorly, they will also go posteriorly. That is known as postnasal drip. Yes, the irritant that has stimulated the sensory nerves, that will lead to itching, that will lead to sneezing, itching. There will be sneezing because of sensory irritation, because of sensory stimulation. Now all these symptoms constitute what is known as rhinitis. Is that clear? So whenever there is any patient who comes to you with a complaint of nasal obstruction, nasal secretions, excessive nasal secretions, post-nasal secretions, of itching, sneezing, then we call that this patient has rhinitis. Yes, and to call it as rhinitis, yes, this what I'm going to tell you now is not very important to remember exactly. But yes, what I am telling you is that if the patient has just the irritant went inside, he had nasal secretions and he started sneezing, and it is over within a minute or so, that is not called rhinitis. What is rhinitis is when it is continuous, at least it lasts for more than 1 hour a day, for more than 2 days. So if today also the patient, he gets up in the morning and he starts sneezing, he has a lot of nasal secretions, tomorrow also the same, and today also for more than 1 hour, for 3 hours, 4 hours, tomorrow also for more than 3 hours, 4 hours, and for 2 or more days, if the patient has the same symptoms of this, then that is what we call as rhinitis. So all these symptoms of itching, sneezing, of nasal discharge, post-nasal discharge, nasal obstruction, yes, for more than 1 hour per day, for at least 2 or more days. 2 or more days. So this last thing you need not remember. But yes, what you need to remember is when all the patient has come to you with all these symptoms, definitely if the patient has one episode of nasal secretions, of sneezing, he will not come to you. He will come to you when it is persistent. So that is what we call as rhinitis. What led to all this? Some stimulant, some irritant. Yes. So now according to what the irritant is the name of rhinitis. Yes. So if the irritant is a virus or a bacteria, then we call it as infectious rhinitis. So if it is virus or bacteria, then it is known as infectious rhinitis, out of which most common is virus. Yes, we know viral rhinitis is so common. You suddenly get up one day and you start sneezing, you have itching, you have running nose. Yes, what is that? That is usually viral rhinitis. And which virus? Most commonly, which virus? It is by rhinovirus. Most commonly by rhinovirus. Now, whenever it is a viral etiology, how do you distinguish it usually from bacterial etiology? Yes, always remember this. This is another thing which will help you always, whether you should be giving antibiotics or not, is that viral etiology you suspect whenever there is an acute onset and there are other systemic features also, like there is prostration, there is headache. It will never be localized to only the nose, only nasal features. If it is present, then that is usually bacterial. This is bacterial rhinitis. But most common is viral rhinitis. Also, if it is for a very long time, patient has been having it for 4 days, 5 days, 6 days, then viral symptoms usually subside in 3 days, 4 days maximum. So if it is continuing, then we know that there is bacterial superinfection that has occurred. So maybe it started as viral. Now what has happened is bacterial superinfection has occurred. So there are other features, generalized features whenever they are present. After acute onset, there are generalized features of headache, body aches, all these things. Then we call it as viral. And the management definitely is symptomatic. Viral, do you do anything for viral rhinitis? What do you do? Yes, you just give symptomatic treatment. Symptomatic treatment if it is viral. And if it is generalized symptoms, that is viral. And localized is usually bacterial. And symptomatic treatment for viral. And if it is bacterial, then we give antibiotics. Antibiotics for bacterial. Now, when the irritant is a non-infectious agent. So what we did is that any irritant, when it enters into the nose, that will lead to reflexly vasodilatation, secretions, postnasal secretions, itching, sneezing. Yes, that is what is rhinitis. When the irritant is an infectious agent, that we call as infectious rhinitis. When the irritant is non-infectious, we call it as non-infectious rhinitis. And in the non-infectious rhinitis, the irritant can be any chemicals, like people who are working in chemical industries. Yes, so they are many a times allergic to that irritant. So that is what is occupational rhinitis. It is known as occupational rhinitis. Patient will specifically tell you that when I go for work, it is that time that I have these symptoms. When I come back, I am okay. So this is occupational rhinitis. So are you seeing the symptoms are the same, but it is induced by different things, accordingly is the name. So when by infection, it is infectious, non-infectious by chemicals, that is occupational rhinitis. By cold, very cold weather, very cold air leads to rhinitis in some people. Yes, that is what is known as cold-induced rhinitis, or it is known as cold-induced, or it is known as skiers. Skiers, people who do skiing. So it is known as skiers rhinitis. Capsaicin, yes, chili, we know that, yes. So that also leads to rhinitis, which is prolonged in some people. So it can also be caused by drugs which cause increase in vasodilatation, like alpha blockers. And it can be caused by estrogens, when it is known as, estrogens also cause vasodilatation, that is what is known as hormonal rhinitis. Now these rhinitis are occasionally sometimes mentioned, sometimes asked. Now what I want you to know is that once you have understood this, what is rhinitis, just these symptoms are what is called rhinitis, and whatever induces them, it is known accordingly. So that is very simple. You need not separately remember that, okay, in viral rhinitis, these are the symptoms. In cold-induced rhinitis, this. Hormonal rhinitis, what is that? Occupational rhinitis, what is that? Yes, very, very important. When the stimulus is something that the patient is allergic to, then that rhinitis is what is known as allergic rhinitis. Is that clear? That is what is known as allergic rhinitis. Very, very common question that is asked in your exam. Many a times allergic rhinitis is asked. So what is allergic rhinitis? Features of rhinitis induced by the stimulus is an allergen that the patient is allergic to. And when you have asked the patient history of allergy, history of exposure to chemicals, he's taking any drug or not, you have ruled out everything and no cause has been found, then it is what is known as idiopathic rhinitis, also known as vasomotor rhinitis, also known as Nanipur. What is Nanipur? Nanipur is non-allergic, it is non-infectious, perennial rhinitis. Is that clear? So I hope you are understanding each and every word of it. So when the cause is not known, that is what is called as idiopathic rhinitis or vasomotor rhinitis. Then it is said that it is just because of increase of parasympathetic activity which is not because of any cause. It is just because of a unknown increase in parasympathetic activity. Now these two rhinitis, allergic rhinitis and vasomotor rhinitis, is very commonly asked in your exam. Why? Because these are the patients who are troubled a lot because of rhinitis. Otherwise, the patient tells that, okay, he specifically knows that I am taking this drug, after this I have started developing. You know that yes, this can be avoided. There are many patients who will come because of some occupational, they exactly know that this chemical, when I go to the workplace, this is what induces these symptoms. So all this can be avoided. Cold induced rhinitis, only when there is excessive cold, dry, cold air. So all that is not creating much problem to the patient. What is creating problem is either allergic rhinitis or vasomotor rhinitis. Why? Because they can be perennial. They can be perennial. Perennial means that they can be almost throughout the year. So when they are almost throughout the year, that disturbs the patient. It is very inconvenient for the patient to sit with a hanky all the time, and he does not know when he will start sneezing. He will have lots of nasal discharge, and that becomes very embarrassing. That affects the lifestyle of the patient very much. So that is why these are the two conditions, allergic rhinitis and vasomotor rhinitis, that you are asked in your exam, and you need to differentiate. Whenever a patient has come to you with these symptoms which are perennial and no other cause can be found out, no stimulus can be found out, then you have to rule out whether it is allergic rhinitis or whether it is a vasomotor rhinitis, so that you can treat the patient accordingly. Allergic rhinitis management will be different from vasomotor rhinitis. So you first need to differentiate. How do you differentiate whether it is allergic rhinitis or vasomotor rhinitis? Yes, allergic rhinitis, always history of allergy will be present. Yes, usually patients tell you that, yes, I have allergies. I have this allergy, I have that allergy. Whenever there is dust, I start sneezing. Whenever there are pollens, I start sneezing. Whenever there is season change, I start sneezing. Yes, I get up in the morning, the first thing I do is I start sneezing. I have lots of nasal discharge. So history of allergy is present. History of allergy is present here. Whereas in vasomotor rhinitis, no such history is present. We know that the cause is not known. The symptoms are same like rhinitis. Symptoms are like rhinitis. I'm just writing rhinitis because I know you know what is rhinitis. Yes, nasal obstruction, nasal discharge, post-nasal discharge, itching, sneezing. Did you tell all these symptoms before I told? You told yes or no? Very good. Okay, so rhinitis, same symptoms. Symptoms are the same. That is why we need to differentiate. Yes. When you examine the nose, can just examination of the nose inside the nostril tell you this is an allergic patient or a vasomotor rhinitis patient? Yes, it can. How can it tell you? Allergic rhinitis mucosa is always pale, boggy. Boggy means very edematous mucosa. Pale, boggy, edematous. Yes. So just see here how the mucosa is. Yes, why is it very pale and boggy? Yes, what is happening here? Because of the allergens, there is the complete pathway of allergy initiated, and that leads to all the release of the mediators, allergic mediators. They lead to leakage of the basement membrane. So because of leakage of the basement membrane, there is exudation of fluid, and that gives the mucosa a very pale and boggy appearance. Whereas in vasomotor rhinitis, what will be the appearance? Think and tell me. What is vasomotor rhinitis? It is idiopathic increase in vasomotor activity. Vasomotor activity means parasympathetic activity. So parasympathetic activity has increased. Vasodilatation. Vasodilatation leads to congestion. Vasodilatation is what? Congestion. Yes. So there the mucosa is congested mucosa. Is that clear? So here in vasomotor, it is a congested mucosa. Now also in allergic rhinitis, there will be external features also which will help you find out. The moment you see the patient, you can tell that this is an allergic patient. How? Yes, just see here. These patients, they have dark circles around the eye. Yes, that is because of the venous congestion. They are known as, yes, venous congestion, which occurs persistently because of the allergy. It happens very continuously. That is what is known as allergic shiners. And because of the venous congestion here, the folds below the eye, they appear very prominent. They are what are known as Denny Morgan lines. Yes, because allergic rhinitis, that will not be only inside the nose. The allergic rhinitis is not confined. The patients who are allergic, when the mediators are released, they will not only act on the nose, they will act on the eye, they will act everywhere here. The patient will have itching in the eyes, the patient will have itching in the nose, the patient will have sneezing. So that a lot of allergy everywhere here will lead to venous congestion, and that venous congestion will lead to the folds below the eye. These are known as Denny Morgan lines. Yes, it is asked in your exam, Denny Morgan lines. And also allergic patients, you will see that they have so much of itching of the nose. They keep rubbing their nose, yes, and they will keep rubbing their nose like that, yes. So that will give rise to, can you see this? Yes, this is what is known as allergic salute. Allergics, yes, because the patient always does like this. This is what is known as allergic salute. And if you now you know this, when you start noticing, you will see so many patients because allergic rhinitis is very, very common. You will see so many people who have this line here, the allergic salute. And just by seeing that, you can tell that, yes, this is a patient who is having allergy. He is a patient of allergic rhinitis. Whereas no such findings will be present in a patient of vasomotor rhinitis. Vasomotor rhinitis will be confined to the increase in parasympathetic activity inside the. So the external findings will be Denny Morgan lines, allergic salute, all this will be present here. Here it will be absent. Now, in allergic rhinitis patients, the symptoms, the history, that is sufficient to diagnose that this is a patient of allergic rhinitis. Still, if you are in doubt, you can get the test done, and what test will tell you that yes, this is an allergic patient. Yes, what is this? What hypersensitivity is this? This is a type 1 hypersensitivity. So, how do we test what happens in type 1 hypersensitivity? Yes, the IgE levels are raised. So, this is the IgE levels are raised. It is type 1 hypersensitivity. Type 1 hypersensitivity. Whereas here, all the test of allergy will be negative. When you test the IgE levels, what is this test known as? This test is known as RAST. The increased IgE levels. IgE levels are tested by RAST. What is RAST? RAST is radioallergosorbent test. Also the skin prick test. Skin prick test is a very important test for allergy. What is done here is that the things to which the patient might be allergic to, they are given in very small doses and the allergic reaction is seen. So that this is useful to give immunotherapy to the patient. What is immunotherapy? Is the same irritant, the allergen, is given in small doses so that the patient gets acclimatized to it. So once you have confirmed that this is an allergic patient, what will be the management? What's the management of allergic rhinitis? All of you should know this. Yes, this will not only help you in your exams, but also there will be so many people around you who will be having allergic rhinitis. Yes, so how will you diagnose? Once you have diagnosed that this is allergic rhinitis, yes, very good. The management will be medical management. What is medical management? Yes, I don't think there is any space there. I will write separately. So allergic rhinitis, the management is you give anti-allergics, you give leukotriene inhibitors. Which are the leukotriene inhibitors? Montelukast. Nowadays, have you heard so many preparations? Yes, Monter LC, Monter FX, Allegra M. Yes, always with that Monter or with M. What is that? That is Montelukast. That is a leukotriene inhibitor. Leukotriene inhibitors you can give, very, very commonly used along with anti-allergics. And what you can give is, along with that, you can give decongestants. You can give very, very important nasal steroid sprays. Yes. Nasal steroid sprays, we will see that in most of the conditions of the nose, we use steroids. Yes, but not oral, in the form of sprays, nasal steroid sprays. So that is a very, very important management. And yes, if required, and if there are certain things that are found out that yes, the patient is allergic to this, immunotherapy can be given. Immunotherapy. The immunotherapy takes a long time. Repeated sensitization is done to the same allergen. Yes, so but still, if it is possible, if it is available, then it can be done. Whereas in vasomotor rhinitis, will all this management help? What will you do in vasomotor rhinitis? Yes, vasomotor rhinitis, there is nasal discharge, there is secretions, there is itching, sneezing. Itching, sneezing is not so much like allergic rhinitis. Mainly the patient has nasal discharge, the patient has post-nasal discharge, nasal obstruction. So there, what you do is, you will section the parasympathetic nerve. Can you section the median nerve? Yes or no? What is the parasympathetic supply of the nose by? Median nerve. Yes, if you section the median nerve, can you section the median nerve? If you section the median nerve, what is that known as? Median neurectomy. Can you do that? Because the cause is not known, so you cannot address the cause. So what you can do is, because it's a very embarrassing situation that all the time there is nasal discharge, you can section the parasympathetic supply, that is the median nerve. But if you section the median nerve, will only the nose be affected? The median nerve is for lacrimation also, nasal secretions also, palatine secretions also. Yes, so we can section the median nerve, but that is not the first management. What is the first management? First management is nasal decongestants and steroid nasal spray. I told you steroids are used for most of the conditions of the nose. Steroid nasal spray. But if the patient does not benefit, in that case you can go for Vidian neurectomy. So if no benefit, then you can go for Vidian neurectomy. Yes. Whereas in allergic rhinitis, so here the surgical management can be Vidian neurectomy. Whereas in allergic rhinitis, will any surgery help the patient? No. So it is very important to differentiate whether it is allergic rhinitis or a vasomotor rhinitis. Why? Because allergic rhinitis patients, you will have to tell the patient that you have to live with this. Yes, but the medicines that I am giving you will not cure your disease from the root, but they will control your symptoms. So whenever you have these symptoms, you can take the medication, but they are not going to cure it. Is that clear? So once the patient knows also, yes, this is the problem that I'm having, half of his problem is relieved, half of his disease is relieved when he knows what the problem he has. Why? Because once he knows that he is allergic to it, he can try to find out what he's allergic to. Yes, is he allergic to some food? Is he allergic to some chemicals? Is he allergic to something, some perfume or anything? He can avoid it. So it is very important to differentiate whether it is allergic rhinitis or it is a vasomotor rhinitis. So here the medical management, the first is in allergic rhinitis. Yes, avoidance is also very important. Avoidance of whatever is the precipitating allergen, precipitating stimulus, and surgical management, no surgical management. Surgical management will not play any role because they will tell you that, doctor, you operate on me and I want to be cured of this. I'm just sick of all this. Yes. So you will tell him that no matter what surgery I will do, this symptoms of rhinitis will persist. Allergies cannot be cured unless and until you can give immunotherapy, but that also only if the allergen has been noted. Otherwise, no surgery. Immunotherapy is also not surgery. Okay, so this cannot be cured. Now, each and every point of this allergic rhinitis and vasomotor rhinitis is a question of your exam. Yes, so Ig levels are raised in allergic rhinitis. What is the nasal mucosa appearance in allergic rhinitis? Pale and boggy. In vasomotor rhinitis, yes, that is congested appearance of the nasal mucosa. History of allergy is present in allergic rhinitis. Idiopathic increase of parasympathetic system is vasomotor rhinitis. Now what we saw is that in management of both allergic rhinitis as well as in vasomotor rhinitis or in any other rhinitis also, what is happening is vasodilatation because of increase of parasympathetic system. Okay, now what you saw in allergic rhinitis as well as in vasomotor rhinitis is that we are using nasal decongestants. Yes, also whenever there is any rhinitis, what is the cause? There is vasodilatation. The cause can be of different things. If you can avoid that, very good. But immediately, what's the symptom? Because of vasodilatation, nasal obstruction. So nasal decongestants are used. And the use of nasal decongestant had become so common that the patient he finds the need of going to the doctor to take a nasal decongestant. Yes, forget about going to the doctor. Whenever you put on the TV, you will find it is very cold. Use Otrivin. Yes, one of the trade name of nasal decongestant, Otrivin. Another, Nazivion. There are so many of them. Yes, they were giving ads in the TV also. Whenever there is hot weather, whenever there is cold weather, whenever there is rainy season, yes, for good breathing, use Otrivin. And recently I heard that now available in 1 rupee pack. So this is something that everybody can afford. You can use it daily. Yes, so use it daily. Yes, no. We saw that these two conditions, allergic rhinitis and vasomotor rhinitis, they are perennial usually. They can be, allergic rhinitis can be intermittent also, but they can be perennial also, which means that the patient, because of, if you don't tell the patient that these nasal decongestants that I'm giving you have to be used for a very short period, he will use it prolonged. So any problem in using it prolonged? Yes, of course. What problem? If they are used for more than 5 to 7 days, more than around 7 days, what happens is, what are they doing? They are causing decongestion. Decongestion means that they are causing vasoconstriction. Yes. So when they cause vasoconstriction, what happens is that the blood supply decreases. So there is accumulation of the toxins. Now once the effect of the drug will be over, once the effect of the decongestant is over, now what will happen is the blood vessels, they will come to the normal, but they will see that there is so much toxins collected. Now to remove all the toxins, there will be reflex vasodilatation. And this vasodilatation will be much severe than the one that he was having because of the disease. So now what has happened is, because of reflex vasodilatation, the patient's nose has again got obstructed. Once the effect of the drug is gone, there is reflex vasodilatation to clear the toxins. Again, because of reflex vasodilatation, again his nose is blocked. So now he feels that, okay, I again need to use the drug. So again he will use the drug. So now what is happening is, the vasodilatation, reflex vasodilatation that is being caused is why? Because of repeated use of the drug, repeated use of the nasal decongestant, which is causing vasoconstriction. And the reflex vasodilatation is occurring to clear the toxins after the vasoconstriction. Because of the vasoconstriction that has occurred, the toxins have not got cleared. So now what will happen? The patient will develop a habit. So it is a habit forming medicine. So now the patient, because of the drug, he is having vasodilatation, reflex vasodilatation and nasal obstruction, and he is using the drug again. So he will get habituated. And now if he uses the drug repeatedly, what is he doing? He is causing persistent vasoconstriction in the nose. Persistent vasoconstriction in the nose means, is he not causing ischemic changes in the nose? Vasoconstriction, decreased blood supply, ischemia. So there will be ischemic changes in the nose, and all that constitutes what is known as rhinitis medicamentosa. Rhinitis medicamentosa. So what's the cause of rhinitis medicamentosa? Again, because this is such a common condition, you will see so many people have been using nasal decongestion for prolonged period, for years together. Yes, so this is a very common question of your exam. What is the cause? Prolonged use of nasal decongestants. Nasal decongestants. So nasal decongestant should not be used for more than, usually whenever you have to advise the patient, tell him use it for 3 days maximum, like that. Yes, but yes, theoretically it should not be used for more than maximum 7 days. 7 days at a stretch. Consecutive 7 days. It should not be used for more than that. The management, by chance the patient has already developed and he will tell you that, see doctor, I used this drops, and earlier when I was using it, I was having, my nose was open and I was having relief. I was getting relief for at least the whole day. I was good. But now what has happened is that I need to use it again and again, maybe so many number of times during the day. So his frequency has increased, his dose has increased. Yes. So now what should I do? Yes. Now in spite of using this drug again and again, I am having nasal obstruction. The moment I use the drug, after some time again I have nasal obstruction, again I use the drug. So what will you do for prevention? You will tell the patient, stop the drug. He is having such a suffocating nasal obstruction. When he stops the drug, he will not stop. He will be forced. Yes, this is breathing. So he will feel very suffocated. He will use it again. So you cannot just tell him that stop the drug without giving him something which can relieve which can give him benefit. So yes, what you have to do is you have to give him again what? Nasal steroid spray. So you have to give him steroids. Yes, preferably local spray, nasal spray in the form of spray. Yes, and if no benefit, if no benefit, then you can go for a short course of systemic steroid. Short course of systemic steroid. And this has been a repeated question. Rhinitis medicamentosa is because of overuse of nasal decongestants. How do you manage rhinitis medicamentosa is again a repeated question. So for managing, you have to give this. Along with that, you will wean off the drug. So steroids, you will give this, plus you will wean off the drug. Wean off the nasal decongestant. So now when this question was asked in the management, local and systemic steroids were a separate choice. The management of rhinitis medicamentosa, what will you choose, local or systemic? Yes, whenever local is possible, always go for local. So yes, local steroid. If not benefited, then you go for systemic steroid. Now just identify this. Yes, are you seeing this such hypertrophic? Yes, turbinate. Yes, this is hypertrophic turbinate, a pale boggy turbinate that you're seeing. Yes, probably allergic rhinitis turbinate. Okay, now just see this. Yes, this again we are seeing that this here is the turbinate like structure. So this is the turbinate, this is the septum. Yes, so we are seeing again this is hypertrophic, this is congested. So this can be because of a vasomotor rhinitis, this can be because of chronic sinusitis. Also notice here, yes, what you're seeing is there is a deviation of the septum. There's a deviation of the septum, and on the side which is having more roomy, again what you're seeing is there is hypertrophy of the inferior turbinate. Yes, so are you noticing in all these conditions there is hypertrophy of which turbinate? Inferior turbinate. Yes, so whenever there is a chronic irritation in the nose which leads to chronic vasodilatation, the inferior turbinate gets hypertrophied very, very commonly. Why the inferior turbinate? Yes, because in the inferior turbinate, which is the turbinate that comes in contact with air the moment the air enters into the nose, the inferior turbinate, the lowermost turbinate. The inferior turbinate is maximum exposed to external irritants, to external drying effect of air, to different temperature variations, and because of that, in the inferior turbinate, the venous sinusoids are very immense. The blood supply is a lot. It is said that the inferior turbinate has erectile tissue. It has got so much of venous sinusoids that the moment it senses any external chronic irritant, or it senses external temperature variation, to immediately bring it back to the body temperature, there is sudden increase in the size of the turbinate, sudden increase in the size of the inferior turbinate to regulate it to the body temperature. Now, when this irritation is chronic, like in allergic rhinitis, in vasomotor rhinitis, what is happening is whatever the cause of the vasodilatation is chronic. Be it allergic rhinitis, that the cause is allergen. Be in vasomotor rhinitis, there the cause is not known. But yes, what is happening is that persistent increase in parasympathetic supply, persistent vasodilatation. The same can occur in chronic infections of the nose, like chronic sinusitis, or like in DNS, there is persistently one side which is exposed to the drying effects of air. So what happens when there is chronic vasodilatation? The venous sinusoids that are present in the inferior turbinate, they permanently remain dilated. They hypertrophy. They permanently remain remain dilated. The mucus glands in the turbinate, they hypertrophy. So all this leads to the inferior turbinate becoming hypertrophic. And when the inferior turbinate is hypertrophic, that is what we call as hypertrophic rhinitis. So what is hypertrophic? Again, this is a very important question that is asked in your exam. Hypertrophic rhinitis. Yes, why inferior turbinate? You know, because there is erectile tissue. What is erectile tissue? That is increased venous sinusoids. So that is what is hypertrophic rhinitis, which means, are you noticing that any condition, hypertrophic rhinitis or hypertrophic turbinate, will not be specific to any condition. It can occur following chronic sinusitis, following any chronic vasodilatation, following allergic rhinitis, following vasomotor rhinitis, following DNS. Yes, so all this can lead to hypertrophic turbinate, and this appearance of the turbinate is what is known as, sometimes it is very irregular appearance, that is what is known as mulberry turbinate. So hypertrophic turbinate appearance, it is asked in the exam, hypertrophic appearance is what is known as mulberry turbinate. Mulberry turbinate. It can be a uniform dilatation, hypertrophy, or it can be irregular hypertrophy. When it is irregular hypertrophy, it appears like this. That is what is known as the mulberry turbinate. And just see here how a normal turbinate looks like, and see how the appearance of a hypertrophic turbinate is. See how the hypertrophic turbinate is, and just see how the normal turbinate looks like. Yes, so can you make out? This here is the normal turbinate. This is the normal turbinate. This is the normal turbinate. Yes, whereas the hypertrophic is a very hypertrophic appearance. So what are the things that we are supposed to know? What is important for us to know in hypertrophic rhinitis is that the cause can be anything, any chronic condition which can lead to chronically vasodilatation of the sinusoids or chronic increase in the secretion, nasal secretions. So it can be a chronic infection, it can be chronic sinusitis, it can be allergic rhinitis, it can be vasomotor rhinitis. Most common site is the inferior turbinate. Inferior turbinate appearance we know is mulberry. And how do you manage? Yes, what you do is reduction of the turbinate. This can be done by cryosurgery, by cautery, by laser, or just by knife. You just reduce the turbinate. Reduction of turbinate, or you call it as partial turbinectomy. Partial turbinectomy. Yes, so just see here, this is the hypertrophic turbinate, and after it has been reduced, after a partial turbinectomy has been done, now see the size is reduced, and this inferior meatus, which was not at all visible because of the hypertrophy, now you can see this opening of the nasolacrimal duct here. Yes, so always whenever we are dealing with the inferior turbinate, we never go for a total resection of the turbinate. Why? Yes, because the inferior turbinate plays the major role in temperature regulation, major role in humidification. Yes, so what we have to do is, whatever the cause is, treat that. Treat the allergic rhinitis, treat the chronic infection or the vasomotor rhinitis so that it does not recur. But you cannot remove the whole of the turbinate. If you remove the whole of the turbinate, what will happen? Yes, you have removed the turbinate, so much of mucosa you have removed. So in spite of now not having any turbinate, do you think now the patient will have a lot of air entering into the nose, so he will feel, I'm able to breathe very nicely now? No. Now the mucosa has been removed. So the sensory receptors of the sensation of the air is gone. Yes, so that will give a false sense of nasal obstruction. So initially, since the hypertrophic turbinate is such a common condition, initially what used to be done was that, okay, so much of hypertrophy that is causing the problem, the complete turbinate used to be removed. And that led post-operatively to the patient coming with a complaint that I cannot breathe, I feel that my nose is blocked. And when you see the nose, no turbinate there. and there is so much of space. Yes, so that gives a false sense of nasal obstruction because the sensory receptors are not there, and that is what is known as empty nose syndrome. Again, that has been a question of your exam, empty nose syndrome. What is empty nose syndrome? Yes, that was asked. What is empty nose syndrome? It is because of complete resection of turbinates. Yes, most commonly which turbinate? Yes, inferior turbinate. And also if it is the inferior turbinate which is playing the major role in temperature regulation. Now just try to answer this question. If there is any patient who is chronically exposed to dry air, like bakers, like ironsmiths, who are exposed chronically to hot and dry air, which part of their nose will be affected? Anterior part or posterior part or whole of nose? Yes, only the anterior 1/3 of the nose. Why? Because by the time this air goes posteriorly, its temperature gets regulated to the body temperature. So the part that will be affected the maximum is what is the anterior 1/3. And when in any patient you see that there is lot of crusting only limited to only anterior 1/3. Yes, otherwise if there is any lot of crusting because of any systemic condition, that will not be localized only to anterior 1/3. You must be thinking that crusting occurring because of systemic conditions. Yes, crust in the nose occur very, very commonly following granulomatous conditions, following atrophic rhinitis, all that we will do later on. Yes, but for now what I want to tell you is that if any systemic condition leads to crusting in the nose, it will be present all over inside the nose. But any patient who is coming to you with a complaint that there's a lot of crusting, I feel there is nasal obstruction, I feel the need of, so I need to clean my nose again and again, there's so much of drying, there is so much of crust, and what you notice is that this crust are localized only to the anterior 1/3. Yes, then what is the cause? The cause is external dry environment. So all that you have to ask the patient to do is avoid the dry environment. Avoid the dry environment. Yes, so this condition is what is known as rhinitis sicca, when the hot dry air leads to changes in the nose. And what is asked in your exam is that rhinitis sicca affects which part of the nostril? Yes, so rhinitis sicca, when you hear, you know that what is rhinitis sicca? Because of drying effect of air, it affects which part? Only the anterior 1/3. So that is what is known as rhinitis sicca. The cause is hot dry air. Chronically exposed to hot dry air, the part affected is only anterior 1/3, and management is avoid. And what can be used is emollients can be used inside the nose for lubrication of the nose. Okay, so quickly to summarize, what we did here is the nerve supply of the nose, and what we saw is that because of any irritant entering the nose, it reflexly increases the secretions and reflexly causes vasodilatation, leading to certain symptoms of nasal obstruction, nasal discharge, itching, sneezing. All that constitutes what is known as, quickly tell me, rhinitis. According to what the cause is, we have labeled the rhinitis named the rhinitis as different. It can be either irritant-induced rhinitis, which can be infection, so infectious rhinitis, not infectious rhinitis, allergic rhinitis, when no cause is known, vasomotor rhinitis. Yes, and whenever we are giving treatment for all this rhinitis, we use nasal decongestants because the cause is vasodilatation. So we have to be very careful that nasal decongestant should not be used for more than, tell me quickly, 7 days. Prolonged use leads to rhinitis medicamentosa, management of which is, yes, stop the drug, along with that wean off the drug, along with that give local and systemic steroids. Allergic rhinitis management is antiallergics, decongestants, but not for more than maximum 1 week. Yes, again steroid nasal spray. Yes, vasomotor rhinitis, again steroid nasal spray and decongestants, but decongestants not for more than 7 days. And also what we saw is that in this, when the vasodilatation occurs, reflexly following any stimulant. The stimulant can be infection, the stimulant can be allergy, the stimulant can be not known as in vasomotor rhinitis. When the vasodilatation occurs, because the inferior turbinate has erectile tissue, lots of venous sinusites, the maximum vasodilatation occurs in the inferior turbinate. And when the inferior turbinate is chronically exposed to these irritants, it chronically remains dilated, the vessels chronically remains dilated, then it leads to hypertrophy, permanent hypertrophy of the turbinate. That is what is hypertrophic rhinitis. Whenever you are dealing with hypertrophic rhinitis, always do a partial reduction, partial turbinectomy, else it will lead to which condition? Empty nose syndrome. And only because the inferior turbinate plays the major role, when there is external drying effect, which part is affected most commonly? Anterior 1/3. What do we call that as? Rhinitis sicca. So is that very clear? Yes, so that was just to summarize. And yes, then you send me messages that, ma'am, you did rhinitis in this module, but you did not do the most important rhinitis, and that is atrophic rhinitis. Yes? Yes, what we have done is the nerve supply, and in association to that, how that nerve supply is important to us clinically, we have done only those rhinitis. Here, atrophic rhinitis is not because of the vasodilatation or reflex vasodilatation following any irritant. So we will do that along with the granulomatous conditions. And again, there is one rhinitis which I would just like to mention in just 1 or 2 lines, rhinitis caseosa. Now, what is this rhinitis caseosa? It is also known as nasal cholesteatoma. Now, what is this condition? Is that there is collection of cheesy material in the nose. Why? Following anything which leads to nasal obstruction. For example, chronic sinusitis, polyps in the nose, So when there is chronic obstruction of the nose, that leads to collection of cheesy material in the nose, and that is what is known as rhinitis caseosa. It is known as cholesteatoma. Why? Because the appearance of the cheesy material appears like the cholesteatoma of the ear. It has got nothing to do with cholesteatoma. Is that clear? Now again, this terminology has almost become obsolete now, and according to the general consensus, it is now believed that what used to be earlier called as rhinitis caseosa is actually allergic fungal sinusitis. Is that clear? So that is why sometimes maybe if some examiner who is from that era might ask you what is rhinitis caseosa. Otherwise, what is asked nowadays, after the advent of endoscopes, it was found out that yes, this is, and now so much of development has occurred that they know now exactly, yes, this is the allergic fungal sinusitis, which is appearing like that. There is cheesy material that is collected. So we will do this in great detail in sinusitis. So I hope the nerve supply is clear to you. The clinical significance of the nerve supply is clear to you. There are many questions asked in this module. So revise it.